didn't know what to talk about, but as a general orthopedic surgeon, I thought I'll talk about general orthopedics, kind of things we all do. If you have any questions now or after, please ask. Carpal tunnel syndrome is a very common thing that we see patients for. Currently, all the doctors in our group, other than our podiatrist, take care of carpal tunnel syndrome. Carpal tunnel syndrome is simply too much pressure on the nerve in your palm, the median nerve. People with carpal tunnel syndrome typically have pain, numbness, and tingling in their fingers. Can be on and off, can be constant, can be at night, can be quite bothersome, can cause weakness. Treatment for carpal tunnel, often vitamin B6, Tylenol, Motrin, a wrist brace, and ultimately surgery. There are different procedures, like most things. There's the typical procedure we do, which is open carpal tunnel release, which is about a 2 or 3 centimeter incision at the palm to release the tight covering over the nerve and when we sew up their skin. You can have it done endoscopically with teeny tiny incisions. Currently nobody in our group does that, and probably 90% of the carpal tunnel surgery in the country is probably done open and not endoscopically, because the endoscopic has higher complication risk of damaging nerves and arteries and things that we don't want to damage. One of the tests that we sometimes order for carpal tunnel is called a nerve conduction EMG test. That is done through a neurology office. They use little needles and shocks, and basically they find out how fast the nerve is conducting its impulses to try to figure out if it's carpal tunnel or a pinched nerve in their neck or some other nerves are involved. So that is kind of carpal tunnel syndrome in a nutshell. And once again, all the doctors here see and treat it routinely quite often. Rotator cuff problems or rotator cuff tears are another thing we often see. The rotator cuff tendons are a group of 4 tendons in your shoulder. The supraspinatus, which is on top, is the most commonly torn rotator cuff tendon. Rotator cuff tears can happen after an injury, or they can just happen as part of the aging process. Certain percentage of people, we get 70, 80, 90 rotator cuff tears. We might not feel it. We might not even complain about it, but it can happen. If it's painful or causes weakness, then obviously they seek treatment. Treatment can be therapy, cortisone shots, ice, anti-inflammatories. If we're concerned that they might need surgery, we do an MRI scan, which obviously we have here. We also order x-rays. For those of you who don't know, regular x-rays basically show the bones. We get a hint of the soft tissue shadows. We can tell if there's much arthritis. Obviously, if there's bone tumors or other things going on, that can be picked up on a regular x-ray. But the regular x-ray does not show the tendons, the muscles, doesn't show the soft tissues. So that's why we order an MRI. The MRI does a very good job of showing the muscles, the tendons, all the soft tissues. It does show the bone as well. If the MRI shows a significant tear or bone spurs or other reasons for surgery, there are different surgical options for rotator cuff disease if it needs surgery. Surgery can be open, mini open, or arthroscopic. The kind of old way, the open procedure is about a 3 or 4 inch incision, come through the deltoid muscle, and then actually take a bunch of deltoid muscle off the bone, take off bone spurs with a little osteotome or a little instrument to bite the bone off, and then you look right at the tendon and repair it. You have a pretty good window to see and repair it that way. But then you have to repair the muscle back to the bone. Theoretically, it's more painful. And then arthroscopic surgery came about. And then a lot of people started doing all arthroscopic repairs, which is 3 incisions, maybe 4 incisions about that big around the shoulder. For a small tear or moderate tear, I think that's a very reasonable way to do it. For a large tear, I think a mini open is, in my hands at least, a better procedure. With the arthroscopic procedure, often their shoulder ends up fairly swollen because of the amount of fluid that we pump into their shoulder during the surgery. With an open or mini open, often there's some less swelling, which might be a little less pain, in my opinion. With the mini open that I do a couple of incisions for the arthroscopic part, look inside their shoulder, clean up the bone spurs arthroscopically, and then if there is a sizable rotator cuff tear or any significant tear that needs repaired, I make about inch and a half incision. Do not take the muscle actually off the bone, but just split through the fibers of the deltoid and repair it that way. And in my opinion, in my hands, I like it that way. I know Dr. Gessler, Dr. Knapper do a lot of arthroscopic repairs and have very good success with that. It's also a good procedure. Dr. Widmer does not do rotator cuff repair surgery. Dr. Jackson does. And I'm not sure if he's I think he's probably an arthroscopic repair guy as well. Dr. Widmer, although he doesn't do rotator cuff repairs, he kind of goes the next step. If you have a rotator cuff tear or if you have arthritis and your shoulder is shot, it's no good. In arthroscopic or open rotator cuff surgery isn't warranted, then you get a replacement. And typically the replacement for a rotator cuff arthropathy or a very bad shoulder arthritis with rotator cuff tear is a reverse total shoulder. And Dr. Widmer is the only one in our group that does that procedure. A standard total shoulder, kind of like a hip or a knee, is basically you're kind of replacing the existing anatomy with metal or plastic that kind of is the same shape and the same design as what was there. With the reverse, if your shoulder is a socket and a ball moving your shoulder around, a reverse shoulder, what used to be the socket becomes a ball, and what used to be the ball becomes the socket. So now the ball is fixed, and when you move your arm, you've got a concave entity moving around the ball. So it's good for bad shoulders. And Dr. Widmer is on that. Did you have a question? Or are you just harassing me?
What is, a little both. What is the difference in the rehab when you're looking at the scope versus a mini open, like lengthwise?
Sure.
Is it
Excellent
pretty
question.
comparable?
Yes, I think I mean, to me, as far as post-op pain, in my opinion, it's very comparable because typically they get a nerve block before surgery. So whether it be an open or a mini open, the anesthesiologist does an interscalene nerve block. So basically they numb up the nerves to the shoulder and the arm, and then they get a general anesthetic. So they're asleep while we're working, but then when they wake up, typically their shoulder and arm is numb for 12, 16, 24 hours, whatever. And they're in an arm sling while that's going on. And then beyond that, it's pain medication. My standard protocol, whether it be an arthroscopic repair, which I've done a few of, or mini open, which I do a lot of, is arm sling for 6 weeks with passive motion. So the therapy or the patient is moving their arm, but they're not actively using that repair. And whether, in my opinion, whether it's mini open or arthroscopic, you're still protecting the same, repair. You're protecting that tendon that used to be pulled away that now is sewn back to the bone. And then the next 6 weeks, I do no sling, active motion, but no heavy lifting, pushing, or pulling. And then at week 12, we start strengthening. I understand sometimes the therapists cheat a little bit, and maybe they're coming out of the sling at week 5, or maybe they'll start strengthening at week 10. But for the most part, that's a fairly standard protocol, in my opinion, in this area. I recently read a study out of France. They're looking at rotator cuff repairs and comparing different procedures, and their protocol was, their rehab was a lot kind of more drawn out than ours. So they were like 8 to 10 weeks in the sling, and then another 8 or 10 weeks before they started strengthening. So they were even further out than that. So.
That wouldn't lead to more stiffness in the shoulder?
That's a concern. In like most things, whether it be a shoulder or an ACL, we're always trying to figure out, is it better to leave them still for a while for tendon healing, but then they get stiff, or is it better to move them and risk the tendon not healing, but then you avoid the stiffness? So we're always trying to find that happy medium. And the healing process is complicated, and does it heal better if it stays still? Does it heal better if it moves? Are anti-inflammatories good for healing? They're good for pain and swelling, but maybe not for healing. So I think it's very simple. Any other questions? And another difference that we do, pointing here, is the arm sling. Because it's cheap and that's the way I was trained, I've always used just a simple $4 whatever arm sling. Some of the docs in the group like the, what's it called? Ultra sling. There you go. That's a little more than $4 is my understanding. And I don't think it really matters either way. If they have a massive rotator cuff tear and you really have to keep them in a weird position to keep the tendon on the bone, sometimes we'll do that for a number of weeks, but for your regular repair that's good into the bone, I think they're fine here. But some people like fancy things, and often more fancy things. Good. All right. Any questions about anything else? Good. Another topic that general orthopedic surgeons do, joint replacement surgery. Currently, all the orthopedic doctors in the practice are doing total joint replacements, whether it be hips, knees, partial knees, that type of thing. With the total hip, one of the big controversies is there the best incision? Is it 2 incisions? Is it minimally invasive? There's posterior approach, there's lateral approach, there's anterior approach, there's direct superior. There's all these terms and kind of different ways of doing the same thing. With any of those approaches, you have to get into the joint, you have to cut the bone, you have to make a hole for the prosthesis to fit in, so you have to mill or ream that out somehow to get your acetabular component in. Once again, you have to get down there and get a reamer in there. So it's kind of a brutal procedure no matter how you're doing it. It's just a matter of which incision do you like and what works best in your hands. Myself, Dr. Gessler do primarily all posterior approaches. Dr. Knappich, to my knowledge, does a combination of anterior and posterior, and Dr. Widmer primarily does anterior. I was just told the other day that Dr. Jackson did a lateral approach for his recent hip that he did in Wooster Hospital. So, and truly, in my opinion, it doesn't really matter. If you're good at your approach, you should have a good result, and your patient should do well. The argument is there less pain? Is there less blood loss? Is there maybe less restrictions? And the answer is maybe. The American Academy of Orthopedic Surgeons, which is kind of the big governing body for orthopedic surgeons in the United States, came out with a position statement within the last year reviewing all the literature and saying there is no proof that one incision is superior. So basically, for your doctor or for whatever to say this is the best, it's just there's no proof. There's no proof that one has less dislocations, one has less blood loss, one has less whatever. So in the right hands, they should all do well. But some people want one thing or the other, and obviously they can go where they want. As far as hips go, there's a variety, kind of like you can buy a Ford or a Chevy or whatever. There are different hip companies. Currently, most of the doctors in the practice use Stryker hips. Dr. Gessler uses Zimmer. But very similar stuff. And once again, basically some type of metal stem that goes down inside the femur, the thigh bone, and then some type of ball, which can either be ceramic, can be metal, and then the cup can either be metal or plastic or ceramic. So there's variations depending upon patient age, patient preference, that type of thing. Most hips done currently, does Dr. Gessler use ceramic ball or metal ball? So he uses metal on plastic. Most of the doctors in the group are using ceramic on plastic. But once again, to argue which is better, nobody really knows. Typically, we do well. We used to use really small balls, 22 millimeter or so. Over the years, we've gone to a bigger ball, theoretically less dislocations. And then total knee replacements or partial knee replacements, kind of the difference. Partial knee replacement, you're just replacing part of the joint. If only one part is arthritic and nothing else hurts, that's a reasonable procedure for some patients. Most patients, by the time they get to us, have arthritis across the entire joint, so we replace the entire joint rather than just part of it. And often with that, we replace the kneecap, which is missing from the bottom. And once again, there's different companies for knees. Dr. Gessler, once again, Zimmer. Myself, Dr. Knappich, Dr. Widmer, and I believe Dr. Jackson do a lot of Stryker. Over the past 6 or 8 months, I've started using a different company for some of my patients, Conformis, which is a custom knee replacement. To say there's proof that, once again, one thing is better than the other, not necessarily. The thought with the custom knee is that by making a knee that fits just that patient, that theoretically they may have less pain, less stiffness, less swelling. You do remove a little bit less bone, I have noticed that. And truly, the fit in the kind of the stability, in my opinion, seems very nice with the custom knee. But the long-term results aren't quite out there yet compared to the knees that have been on the market longer. The custom knee, I think, has only been on the market 6 or 8 years, where the Stryker Triathlon has probably been on the market 10 to 12 years. And so the track record just is longer. To say it's better, we don't know So to do the custom knee, they get a CAT scan. The CAT scan gets sent to somewhere in the United States. They use a 3D printer to make the metal on both sides as well as the plastic inserts. They actually make a bone model like this for each patient to help with the fitting, and then it gets sterilized and it gets sent in a box to the hospital, and we put in the knee that just fits that particular patient. Yes?
Can you explain when you cement and when you press fit and why?
Great question. That was on my list of things.
Sorry.
No, I already Thank you. A knee or a hip can be press fit or cemented. We'll start with the hip. So when you put in the stem, you can either make this hole just a little bit smaller than the piece of metal that you pound in there. But you have to pound it in there. And if the patient is osteoporotic, you could split their femur. That can happen during surgery, it can happen after surgery. So in my hands, and my thought is a patient 70 or older, especially if they have any osteoporosis, I'm typically going to cement their femoral stem. With cementing, you make the hole about 1 millimeter or 2 bigger than this. You put cement in there, and then you put this, you still have to pound it in, but there's some give there with the cement. The cement hardens, and then it's done. With the press fit, you're relying on the bone to actually grow onto the metal, which takes time. But it still does very well for most patients, especially if they have good solid bone. The cup is typically press fit. We can put screws in it to help stabilize if we need to, but for a primary total hip, almost never do we put a cemented cup in. For knees, knees can be cemented or press fit. My guess is that probably 80% of the knees in the country are put in cemented, but that's just a guess, could be a little off. Most of the doctors in our group do cemented knees fairly routinely. Theoretically, in a younger patient, 45, 50, maybe early 50s, by putting in a press fit without cement, it's just one less thing that can break down. Cement is one more material that you're putting in between there and theoretically can break down with time. They used to call that cement disease, but probably what was happening, rather than cement just breaking down, is that with time the plastic can wear. And if the plastic starts to wear, the body sees that microscopic particle as an invader, as something bad, something to get rid of. So it sends cells that start eating up those plastic particles, and once it starts to eat things up, it's there and it starts to eat up the cement, maybe the bone, and that's what they used to call cement disease. It really wasn't the cement's fault. So either one is a good design. Typically either one does just fine. You can do a total press fit knee, you can do a total cemented knee. Some people will press fit the femur and cement the tibia and the patella. It can be dealer's choice. The cost is a little different.
Okay, but healing-wise, if you have cement versus press fit.
For a knee, I'm not aware of anybody that changes their rehab, and that's probably where you're getting with this. Is there a different rehab protocol? To my knowledge, nobody changes the rehab protocol for a press fit or a cemented knee. It's basically range of motion, weight bearer is tolerated, be careful. For a hip, I used to routinely keep my press fit hips partial weight bearing for about 6 weeks. And the reason I did that is because where I trained, that's what they did. And the thought is if you break your arm, it takes about 6 weeks for the bone to heal together. So my thought was it probably takes about 6 weeks for that bone to grow onto the metal and really stabilize it. Since then, about 20 years ago when I finished training, they have done more studies showing that weight bearing is tolerated for a press fit hip is probably just fine. There's probably not enough micro motion to slow down the bone healing onto the metal. So if you got a good fit and you're happy with things at the time of surgery, you can probably let them weight bear as tolerated as well. Although once again, it's surgeon choice. Whether they feel comfortable letting the patients do that. Good questions. Yes, sir.
With your direct superior, are you still dislocating the hip posteriorly to get access to it?
Yes.
Okay.
Exactly. The big difference between the direct superior and a regular posterior approach is how much of the fascia lata you cut.
Okay.
Basically, with that procedure, you're really not cutting anything. You're sitting at the greater trochanter above. And also with that procedure, if you're careful, you can preserve their hip capsule and repair that on the way out. With the typical posterior approach, you're coming down a little bit further down the thigh, getting in their fascia a little bit more, and then also the capsule typically when you're done kind of isn't still there to repair, and you just repair the other soft tissue when you're done.
And then with your direct superiors, do you want the same hip precautions as a posterior approach?
In my opinion, yes.
Okay.
Knock on wood, I've not had any of my total hips ever dislocate, and I like that statistic. So I try to tell them not to go beyond 90, which they all cheat and tie their shoes. Some of them cheat and trim their own toenails, but I still harp on them not to, but they still do. So, but the longer they wait before they try those things, probably the better. I don't know how many more direct superiors I'm going to do. I've done a couple of them, a couple of hemis, and honestly, I don't think it's. I think it's a marketing thing, kind of like the 2-incision kind of minimally invasive or this or that. I'm not against marketing, but I also want to do what's best for my patients. And sometimes, and it's a smaller incision. And sometimes smaller incision, you're kind of really tugging at the skin edges, and I don't know if that's good for wound healing and everything. So I've certainly the posterior approach we used to do literally was probably a good 4 inches down the shaft of the femur up to the tip of the greater trochanter, and then another 4 or 5 kind of onto the butt. So it's a big old curve thing now, and we've done away with almost the whole thing down the shaft, and we just kind of do a little curve thing. Now, people usually see that already. Question?
What's the difference between hemiplasty and arthroplasty? I mean,
That is a great question too. Yes.
Okay.
Hemiarthroplasty is hemi meaning partial.
Okay.
So it's a part of a total hip. So for a patient that's of a certain age that falls and breaks their hip, especially years ago, no matter how old you were, if you broke your hip, you got a hemiarthroplasty. It was just the procedure we always did for a broken hip. And often even a PressFit, which is now considered maybe a bad idea. Because if you're old enough and osteoporotic enough to break your hip, to put a PressFit stem in might not be a great idea because the bone might not be that strong. So in my hands, I almost always cement my hemiarthroplasties. There are some studies now showing that for those people that break their hip and live a long time, which hopefully they do, they might end up getting hip pain and arthritis because you didn't replace their socket, and now you have a new ball, typically metal, not plastic, but you now have a new ball that, although is a very similar size, may not be the exact size what they had in there, or the exact shape. I mean, not everybody's femoral head is exactly round. And so their cartilage and their acetabulum is used to that size and shape, and now you're putting something new in there, and maybe for 3 or 4 or 5 years they tolerate it, but theoretically 5, 10, 15 years later, the cartilage can start to break down, which now you've got an arthritic socket, but you've only got part of the hip down. So the kind of the new thought process, relatively new thought process, is if you have a kind of a younger hip fracture patient, why not just do a total? Go ahead and replace their socket at the same time. The dislocation rate's a little bit higher with that, and it's a little bit bigger surgery, a little more blood loss. But kind of Dr. Widmer's unwritten rule he told me recently is if he has a patient that he thinks is going to live longer than 5 years beyond their hip fracture surgery, he does a total. So I kind of use an age of 70 is my cutoff, that if they're 70 or older, I typically just do a hemi. And I've got a lot of hemis out there that have been in for years and aren't having pain. But we all have a handful that if they've been in 5 or 10 years, they're starting to get some pain, probably from the cartilage wearing down because we didn't replace it. And then there's a unipolar or a bipolar hemiarthroplasty. The difference there is a unipolar hemiarthroplasty is one big ball, just one big piece of metal that fit whatever they had. A bipolar is kind of two, kind of a ball on a ball, so there's theoretically some more motion there. Most of us do unipolars, just one big ball.
Is there any reason to talk about why you do a hemi versus cannulated screws
Yeah, we
versus
can talk about that, yeah. Another option, if you break your hip, femoral neck fracture, if the fracture is fairly well lined up, sometimes we'll just put 3 screws in it to hold it together and try to get it to heal. And if it's fairly lined up to begin with and we get there relatively soon to do that, usually they do heal. There might be a little deformity, but if we can preserve their own anatomy, and that surgery is, an incision this big and takes 40 minutes tops, where, hemiarthroplasty probably takes an hour, hour and a half, and it's a bigger incision. So that's another option. Or for further down, we do the intramedullary nail or hip screw side plate for fractures that are a little further down in the intertrochanteric region.
Could could you explain why our physicians will not do a hemi on a hip unless there's a fracture there? Like if it's just severe degeneration, or not even severe,
So why doesn't somebody with arthritis
get a
get a
hemi rather
hemiarthroplasty
than a
for the
total?
hip? That's a fine question. And we used to do that a lot in shoulders. If somebody had shoulder arthritis, and if their glenoid, the other part of the ball and socket for the shoulder, looked pretty healthy, people would put in just the new ball and leave their cartilage alone for shoulders. And that's probably still done somewhat, but even in the shoulder, which is not a weight-bearing joint, often those don't get the same amount of pain relief, and certainly not the same pain relief long-term as a total shoulder. Same with the hip. I'm not aware of anybody or any study, but it probably exists, looking at ignoring, typically when they get arthritis, it's on both sides of the joint. It's not only in the ball, it's in the socket. I'm not aware of any study that I could look at myself. I'm probably not bored enough to do that. Looking at...
Because there's a code for when it's not a fracture, you use
so
this
there is a code for hemiarthroplasty for arthritis. Interesting. Never done it, never seen it, never thought about
Well,
it.
that's-
So just now.
I had asked a long time ago, and Dr. Gessler had said we would never do a hemi
For arthritis.
unless they had
A
a
fracture, yeah. Because often with the fracture, the cartilage is still healthy and good. Most of those, interestingly, don't have pre-existing arthritis. When they get a hip fracture, whether it be an intertroch or a femoral neck, usually, interestingly, they don't have much arthritis there. So if their socket looks healthy and they're a little bit older, I'll do a hemi. If they're arthritic or if they're younger, do a total. And I'm not aware of anybody that does partials for hip joint arthritis.
What percentage of, say, people who fall
Okay?
and have a fractured hip are due to, like, they fractured then fell? You know, due to arthritis?
That is, we don't know.
Okay, I wasn't sure because I was kind of surprised what you just said.
We do have patients that swear that they twisted, they felt something break or shift, and then they fall. But we don't know if they really broke and then fell, or if something happened that hurt, they fell, and then it broke. So we really don't know. But once again, most people that have a broken hip don't have much pre-existing arthritis.
Do they have, are they osteoporotic?
Yes.
That's usually
Yes,
the case.
that's
So
usually
we're looking
the
at that
case.
completely different.
Exactly. Because as we get less young, bone remodeling, hormonal changes, activity, all the things that go into it, our bones are less strong. We'll talk about that. That's a good thing to bring up. Normal bone, and then there's osteopenia, and then there's osteoporosis. Normal bone mass, obviously, hopefully we all have at this age, but as we get less young, you get a little bit weakening of the bone, which is called osteopenia. If your bone's even thinner or weaker, that's called osteoporosis. The only way to truly diagnose that is with a DEXA or bone density scan that can be done, and it is recommended to be done after basically any fracture beyond age maybe 50 or 60, that we should be getting more bone density tests on people to see if they have osteoporosis. And it's very common as we get less young, and that's wrist fractures, shoulder fractures, hip fractures, vertebral compression fractures.
Meaningful use thing, remember?
Yes, yeah. Yeah, and honestly, I know I'm not great at it. I like to think I'm great at most
It's no
things.
longer a thing
but,
anymore, so
oh, it's
don't
not?
worry about
Well,
it.
good. I'm glad I saw it.
Well, I
Yeah,
guess I want to say, your question is, if you have someone who has like severe osteoporosis,
Okay,
are their joints usually pretty good, or is it just kind of a,
it's
Random.
almost an unrelated problem.
okay,
Osteoporosis is a bone density problem. Osteoarthritis is a joint, articulating joint problem that both happen more as we get less young, but it's two completely separate disease processes. You can have one or the other, you can have both.
But
But
you have to see
osteoporosis doesn't cause osteoarthritis.
Right.
Now, if you have osteoarthritis and your hip and knee hurts and you don't want to walk around anymore, that may make you more prone to osteoporosis, because one of the ways of avoiding osteoporosis is weight-bearing activity.
Does osteoporosis cause you to have pain?
No, not unless you have a fracture. Osteoporosis is a non-painful condition. Now, if you get a stress fracture, you don't know you have it. But if you get a stress fracture, then you fall. Then you know. If you fall in what didn't used to be that traumatic, but then you break the wrist, then it hurts. But, in and of itself, it doesn't hurt.
see.
You should have said up front.
I know, right? Or ankle scopes or a hip scope?
That's a great question. I have scoped probably 2 elbows in my life and probably 2 ankles in my life, and I don't plan on doing any more. I don't know Dr. Jackson's preferences if he scopes elbows. I did ask yesterday if he scoped hips, because I had a patient, an adult that needed hip scoping. He does not scope hips. And I don't know if Sonia Morris scopes ankles.
I've not seen her do any, and I've not done any pre-ops.
A hip scope is a fairly complicated procedure, and the indications are pretty limited. And I have a feeling that a lot of the people that we send for a hip scope probably don't end up with a hip scope because the indications are fairly limited. But there are a certain percentage of people that benefit from it. The hope with a hip scope is, and it's usually done for femoroacetabular impingement, which is basically the ball and the cup aren't liking each other anymore. You're either getting bone spurs on the cup or bone spurs in the ball. They're kind of pinching in there, and then your labrum gets irritated or torn, and then they go in, repair the labrum, kind of smooth off the bone spurs, and kind of clean up your hip joint. And the hope by doing that, 1, it takes away pain, and 2, hopefully helps you not get osteoarthritis too early on down the road. And some of the early studies are showing that it is hopefully changing things enough that it is helping prevent early arthritis. But the indications are pretty limited for that. And the procedure itself is not real straightforward compared to a knee or a shoulder. Part of that is when we trained. When I trained, nobody was doing hip scopes. You know, they were starting to do a lot of shoulder scopes, and certainly doing a lot of knee scopes. And then same with ankles, the indications aren't quite as great as for knees, but certainly it's a doable thing. But currently, I'm not aware of any of our doctors trying to get additional training, and that's what it would take if you want to start doing a lot of hip scopes or things you're not used to, additional training to do that. I don't know if the numbers are there. Why do you need one?
I hope not.
Good. We'd send you to a children's hospital.
Let's talk about that, right? So, do your total hip or total knee procedures change approach maybe, or I don't know, when you're looking at somebody with a much shorter stature versus somebody of a normal stature?
Most of the non-custom implants fit a wide range of patients. But if we have somebody that's either really big or not so big, we can template it ahead of time to try to determine, is that a standard size? So for a non-custom made prosthesis, we don't like to get in the room and realize we don't have the size that's going to fit, which has never happened to me or any of my partners I'm aware of, but that's because of careful planning. And sometimes if we know the patient is really big or really small, they can send in additional sizes. Currently, the only custom knee that I'm aware of is the conformist, and for that it doesn't matter what size you are because they're building the knee to fit you. In the next couple of years, supposedly conformist is going to come out with a custom-made hip prosthesis as well. But I think it can be done. Good questions. Any other questions? Thank you for your time. Enjoy your pizza.